Welcome to the pre-congress session on financing and providing healthcare to 2 billion people in low and low-middle income countries for UHC. I am Winnie Yip, and I am a professor of global health policy and economics at the Harvard Chan School of Public Health. I happen to be this year's IHEA president as well. So let me try to spend a few minutes to lay out the context of this session. This session is primarily concerned with the population who lives in low or low middle income countries who still do not have affordable access to essential healthcare with reasonable quality. You might call it UHC, but I'm trying to be a little bit more concrete. So it's affordable access to essential healthcare, not everything, but at least with some reasonable quality. So that's the population, and that's the problem that we're trying to examine. The context is that these people live in countries where general tax revenue financing is limited. The usual sources of financing, general tax revenue financing is limited. Contribution-based type of social health insurance is also not quite feasible because of the large informal sector, rural population. And donor financing may tend to prioritize specific diseases or maternal and child health program rather than general care. And also, we typically see that there is high out-of-pocket spending. In other words, it's not that people are not spending, they are spending, but the question is spending on what? And on the service delivery side, the public service delivery are typically not very convenient. Either they are not located very close to where people live, or if there is a facility, the health workers may not show up, for example. Quality of care for both public and private is still variable, if not low. And there's also a questionable efficiency of service delivery as well. And of course, what I just described is the general condition, and there are exceptions. So the question that we're trying to address today, or the objective of today, is to have experts and also the audience share innovative concepts, ideas, or lessons that include both what works and what doesn't work, that might generate some solutions for improving the care that this population will have. Some of them could be proven solutions, where some of them may be new ideas that might be primed for experimentation and testing as well. Today, we're very delighted to have four very renowned experts in healthcare system. The first one is Edwin Barasa. Edwin is the director of the Nairobi program of the Camry Wellcome Trust Research Program, and he also has the program's Health Economics Research Unit. He brings global experience, but in particular experience from Africa. The second panelist is Professor William Shao. I think most of you know him by reputation. He is an expert in healthcare system with 40 years of experience in working in many countries, in particular China, and you name it. I'm not sure which country has not worked in yet, so you can ask him. And then Joe Cutson, who is director of the Health Systems Governance and Financing Department. Like Bill, he also has lots of global experience. And then Ajay Tandon is the lead economist of the Global Program on Health, Nutrition and Population at the World Bank, currently based in India, but with worldwide experience. I'm going to propose the following format. I'm going to invite the four panelists to each speak about 12 minutes. And then after that, there will be a moderated discussion among them, and we'll leave plenty of time to have a conversation between the panelists and the participants, the attendees. You can type your question in the Q&A box, and when you type a question, I'd like to ask you to identify who the question is addressed to, so that we can direct your question to the right person. I just want to acknowledge that this session is sponsored by the Bill and Melinda Gates Foundation India Country Office. So without further ado, I'm going to invite Ajay to start sharing with us his view.
I'll basically give you a sense from India. And I ask if people can focus more on, not so much on the details of India's reforms and how it's trying to expand universal health coverage, but more the principles behind what they're trying to do. And just before I get into the details, just wanted to give some background and context on India, because I think that's very important to understand the context of the reforms themselves. So India's population is 1.3 billion. It's second largest after China. So Winnie, this covers, I guess, 2/3 of your 2 billion people in your title. India is a lower middle income country. National income is roughly $1,900 per capita, which is very similar to Bangladesh, Nigeria, and Vietnam. It has it's a federal democracy, and it has 3 administrative levels. It has the center, it has states, and also it has local government bodies. The local government bodies are basically local urban government bodies like municipalities, but also local rural government bodies at the village level and at sort of other administrative levels. India currently has 28 states and 8 centrally administered union territories, and health is a state subject in India. So that's also very important to keep in mind, that states are the ones that have the primary responsibility for provision of health. But there's also a very important role for centrally sponsored schemes. So basically, centrally sponsored schemes are sort of specific purpose intergovernmental fiscal transfers in the country. They are not only for the health sector, they happen in other sectors, and basically where the center co-finances some specific categories of objectives that they want to implement. For instance, bolstering primary health care is implemented via a centrally sponsored scheme. The center puts forth money and guidelines, and the states have to co-finance and implement, and it is monitored. So a sort of a unique structure within which health reform is taking place. If you look at the right-hand panel, just wanted to also make the point that India is also very, very diverse. So it's sort of many countries in one. There are huge variations across the states. So you have some states like the state of Haryana. The size is 29 million. The Union Territory of Delhi, the state of Goa. These are equivalent to upper middle income countries. So Goa is richer than Thailand, and Delhi is richer than South Africa. Haryana is richer than Indonesia, but at the same time, you have several lower middle income states, and then you also have low income states such as the state of Bihar and Uttar Pradesh, sort of at the bottom end of the income spectrum. It's quite startling, this inequality within the country in terms of income. So for instance, the state of Goa is 10 times richer than the state of Bihar. Bihar is about $700 per capita. Goa is $7,000 per capita. So it's huge variation to keep in mind. Basically, hold on one second. I seem to have gotten stuck here. So just to give you a little bit of background on the performance of India and health outcomes, there's been steady progress in the past couple of decades. Life expectancy is now up to 70 years, up from 58 years in 1990 and only 41 in 1960. India's under 5 mortality rate is now 34, and infant mortality is 25. And if current trends are sustained, India is expected to meet the 2030 SDG target of an under 5 mortality rate for 25. So I think the point I wanted to make here is that progress has been occurring in the country, but this progress is less sanguine if you sort of look at what India is doing relative to its income and relative to comparator countries. So attainment for several population health indicators in India is about average. It's what might be expected for its income level. In some cases, it's slightly above average for life expectancy. I've not shown that, but in other cases, it's slightly worse. Malnutrition rates, for instance, are very high in India. Also, if you look at the progress that India has made, it looks less impressive when you see the fact that countries like Nepal and Bangladesh actually have better under 5 mortality rates than India. And also India is one of the few countries in the world where the under 5 mortality rate for girls is actually worse than for boys. And also, if you look at the maternal mortality ratio, it's double the SDG target. It's 145 per 100,000 live births, and it's 3 times worse than Vietnam. So hence the point about mixed performance on key population health outcomes. One way to understand this mixed performance that India has is to also look at the coverage across states and performance across states. Let me just try to, my slides are getting stuck. Okay, so here I'm just showing you the slides, the same slides with the states also highlighted. And I think the key point here is that, as I was making the point, there's huge income differences across the country, but also huge differences in health outcomes. So for instance, the state of Bihar, under 5 mortality is 10 times higher in Bihar compared with Kerala. And if you also take a look, Kerala's under 5 mortality, Kerala is a state in the south of the country. It's actually better than Sri Lanka, Russia, China, Malaysia, and Thailand. So even in sort of such an environment of being a lower middle income country with challenges related to incomes and financing and so on and so forth, you do have these remarkable success stories. And they're not just isolated. You see states such as Tamil Nadu and Goa also doing well, very well relative to their income levels in the country. In terms of UHC tracer indicators, the country has made good progress in terms of, especially in terms of improving coverage for reproductive and maternal health services and for infectious diseases in particular. The antenatal care visits have gone up. Skilled birth attendance rates are about 80%. But there are still some challenges. So access to basic sanitation remains low. And also coverage for NCDs is quite poor, and quality remains a challenge. There's unmet need, and there's huge catastrophic health spending. So the out-of-pocket spending as a share of household income is very high. So more than 17% of individuals face more than 10% of their household budget in out-of-pocket spending for health, and 4% had more than a quarter of their budget. And you have very high rates of catastrophic spending, primarily because out-of-pocket spending is a primary way in which the health system is financed. So in India's case, you have out-of-pocket spending, which is almost 2/3 of current health spending. And the reason it is so high is there's very low public spending. It's only about 1% of GDP, and it's remained at that level for decades. So that amounts to around $20 per capita is public spending on health, both center and state combined, and about 2/3 of that happens at the state level. So a very challenging environment in terms of public financing for health, and the part of the reason for this low public financing is low priority of health in government budgets, both at the central level and also at the state level. So the overall tax revenue collection is not so much of a challenge in India. It's really the priority that goes to health that's a bit of a challenge. And as a result, not by design, but by default, India has actually become one of the most privatized health systems in the world, not only in terms of financing, but also in terms of utilization. So that's what the graphics on the right-hand side are showing. On average, about 70% of outpatient utilization occurs in private providers, and about 58% of inpatient utilization occurs in private facilities. And that's the average, but this is also quite high among the bottom 40%. If you take a look, the orange shows you utilization in government facilities, the blue and the brown showing you in private facilities. So a huge role for the private sector, and increasingly we're also seeing in many cases the first point of contact in the health system is actually becoming private pharmacies. They're open late, they're nearby, they seem to know what's, at least for some basic health care, are able to provide care. So given this background, just wanted to give you a flavor of the types of reforms the country is implementing. And that the term for the reforms is called Ayushman Bharat. Ayushman just means long live India. And I'll just, in the next couple of minutes, just give you a small flavor of what the country is trying to do. So basically, there are 2 pillars of this reform, which has been going on for the past 3 years or so. The first pillar is really around the strengthening of the public delivery system, the public primary care delivery system. So in terms of converting primary health centers and provision of comprehensive primary health care at public facilities by converting them into health and wellness centers, including diagnostics and bolstering provision of NCD care and free medicines and so on and so forth. So that's one pillar of the reforms, focusing mostly on primary, a little bit of secondary, but only focusing on strengthening the public delivery system through its interfiscal governmental transfer system, which I mentioned, which is called the National Health Mission. The second part of the reform focuses on inpatient care, and it's about expanding tax-financed insurance coverage for inpatient care, for secondary and tertiary care, but both at public and private hospitals. So actually, India has more private beds than public beds, and this sort of tax-financed insurance coverage program targets the bottom 40% of the population, and it's called the PMJ program, or the Pradhan Mantri Jan Arogya Yojana. So just a little bit more flavor on the second aspect of the reform, in that it's national in scope. It's implemented by almost all states. The eligible population, as I mentioned, is about 500 million people. These are poor and near poor, really the bottom 40% of the population. Okay. Beneficiaries get explicit benefits that they can avail of in public and panel private facilities. There's cost sharing, and the beneficiaries can avail benefits up to roughly $7,000 per family per year, and it's implemented by a new purchasing agency called the National Health Authority. The right-hand side shows you that as the country was implementing reforms, they also implemented a way to finance those reforms by actually adding a 1% tax. It's called a cess in India. So it's basically everybody who pays an income tax, all formal individual income taxpayers and corporations, whatever tax they pay on their tax return, they add on 4% of that, and that is sort of an earmarked fund. It's not hard earmarking. It goes both for health and education cess, and I think the indications are about 1% of that is actually for expansion of this tax finance program. The key point to remember is this was used as an excuse to raise taxes on the formal sector and the well-off, but they are not the beneficiaries. So it's basically expanding taxation to pay for coverage of the poor. And this is my final slide, just to give you a flavor of the reforms and just to talk a little bit about the pros and the cons in terms of the principle. So the principle here was, the public financing was targeted firmly towards the poor, both in terms of the NHM reforms and the PMJ reforms, and it gives an incentive to the public sector to prioritize the poor. The reforms were used as an excuse to raise progressive taxes from those who actually are not going to benefit from the program. And the program gives some flexibility to allow states to actually expand coverage beyond what the center mandates. It's calling for integration of public and private provision using public financing, and by bringing in treatment protocols and case-based payments, they're also solving some of the principal agent problems that are inherent in financing. And also, most importantly, PMJ, it's giving an ecosystem and a platform for consolidation of other schemes. So India has some formal sector social health insurance schemes for the public and private sector. So potentially the platform has been put in place to now integrate as needed and expand further. Of course, some challenges remain. I think the biggest challenge is that primary care is separate from inpatient care. It's run as a separate program. Primary care is not there in the PMJ benefits package. And also the levels of financing are not that high. So the central outlays for PMJ are amounting only to about 0.03% of GDP. And we risk having the problem that the program for the poor becomes a poorly implemented program. And there are complaints that the resources are not enough, and there's a potential for growing inequalities across states. And of course, in a country such as India, lower middle income country, really the poor, near poor are more like 80% of the population rather than 40. And so there are plans afoot to try and expand that. So I'll end here. We need just to give you a flavor of the sort of the large scale and the types of reforms and the principles behind those reforms in the Indian context.
Great, thank you very much. Thank you very much, Ajay. there's no one in a better position to give that overview and update and critique of India, and we'll come back to some questions. I'm going to turn it to Edwin. Edwin?
Just, moving on from Ajay's presentation, focusing on how low and middle income countries can raise additional finances to finance universal health coverage. And my starting point here really is to think about, what is the question that you're trying to answer? And the idea is that it's not just about raising additional funding for health, but a good health financing system has to be a system that raises additional financing that can provide services for people that need them, but also protect them from financial catastrophe. But beyond that, it has to do that in a way that ensures that there's efficiency in mobilization and allocation of resources, and that there's equity in contribution of benefit, in contributions and benefits, and that the financing mechanisms are sustainable. So that's really what we're thinking about when we think about a health financing system that mobilizes funds for universal health coverage. And when we think about options for mobilizing additional financing for health, Ajay and Cheryl came up with this framework of fiscal space for health that essentially outlines 5 options for mobilizing additional financing for the health sector. One of that is conducive macroeconomic conditions. So, when an economy grows, then ideally per capita spend on health should go up, and the health sector should get more just by virtue of that. Or prioritization within existing budgets. So, the share of government budgets that goes to health could be increased. There's also potential to do that through efficiency gains. There's potential to do that through earmarked taxes, so taxes that are specifically targeted to the health sector, and these could come from public health taxes, such as taxes for, sugar, alcohol, tobacco, and so on. Other indirect taxes, such as earmarked taxes on VAT, such as what is happening in a country like Ghana, and social health insurance as a form of earmarked funds for the health sector. The health sector could also mobilize additional resources through efficiency gains and through external sources. So I'm going to talk about experiences from LMICs with regard to the potential for these options to raise additional resources for health. I will talk about the 4 and exclude external sources because of time. So when we think about whether conducive macroeconomic conditions can improve fiscal space for health, several reviews have been done around this, and the general consensus is that it really depends. It really depends. So if you ask the question, if a country's economy grows, does the funds that go to the health sector also increase? And the answer is that it depends. And in countries where you have positive macroeconomic prospects, then there's a higher potential for the health sector to benefit from economic growth. While in countries where there are poor prospects for macroeconomic growth, the general finding is that there is very little prospect for increasing fiscal space through improving macroeconomic conditions. But that is really about the potential to improve fiscal space for health. But when you look at what happens in practice, again, it's not that straightforward or linear. So there's an analysis that was done in 3 countries, Kenya, South Africa, and Nigeria, but I'm going to focus on Kenya and South Africa, that looked at the relationship between increase in, rather growth in a country's economy and prioritization of health. And what you see here for Kenya and South Africa is that over a period of time, while total government expenditures increased over time and total government revenues increased over time, the share that goes to the health sector didn't actually increase over time. They remained fairly stable, and the level and the prioritization remained fairly stable over that period of time, and the experience was similar for Kenya and South Africa. And that, in fact, when you look at the relative prioritization of the health sector with regard to other health sectors, while these 2 countries' economies grew, when their revenues improved, the health sector lost out to other sectors. So, its ranking in terms of allocation of budgets actually went down across that period of time. So what this tells us is that while there's a focus on thinking about the potential for raising additional funds, in practice, it's more complex than that. And there are many other issues that come into mind when you think about whether in practice an improvement in macroeconomic conditions would result in improved fiscal space for health. The second approach that or option that countries have is through budgetary prioritization. So allocating more funds to the health sector from existing government budgets. And again, here it depends. For countries where their starting points are low, so you have countries where the share of the health budget, the health budget as a share of the total government budget is quite low, then there's potential to have gains in fiscal space by reprioritization. But in practice, what has been seen is that when you incorporate a political and economic considerations, when you look at whether it's actually practically feasible from a political economic standpoint, the evidence shows that there's quite little prospect in terms of improving fiscal space through reprioritization because of government commitments to other sectors. And in fact, there's an analysis that looked at what happened 10 years after the Abuja Declaration. And what it found is that for the African Union countries, as much, there was a number that increased their funding, but an equal number reduced their funding over that period of time. So again, emphasizing this point that it's not that linear and straightforward, and that politics plays a role. And so the question then is, how do you get to take advantage of budgetary prioritization as an option? And what we see from literature is that what countries have tried is to legislate, for instance, as an option. So Vietnam, for instance, passed a law to guarantee increases in health budgets as a way to ensure that reprioritization actually works. And another approach has been for governments to be very explicit about what commitments they are going to make for their citizens in terms of health entitlements. And we see this in Chile. But for such a thing to happen, for these commitments to actually translate into fiscal space for health, it has to be underpinned by accountability. And so if the governance arrangements within countries are such that governments are not accountable to their people, then commitments don't really mean anything and don't translate to increased resources for the health sector. The other approach is earmarked taxation. And what we see from literature and experiences from several low and middle income countries is that earmarked taxation have limited potential for additional fiscal space, for increasing fiscal space for health. And examples include, for instance, the potential gains that countries would get from imposing public health taxes, such as tobacco taxes. And a literature review across 44 countries found that, or rather, the representative of 44 countries found that tobacco taxation had the potential to only increase between 0.02% and 0.05% of GDP, which is quite little. The potential for other earmarked taxes, such as mobile phone levies and remittances and so on, is also quite low, translating to about 1 to 2% of actual health spending, just signaling the limited scope that earmarked taxation has in terms of improving fiscal space for health. When you think about social health insurance or health insurance in general as a form of earmarked funding to health, again, experience shows that there's quite limited potential for low and middle income countries to gain fiscal space from these approach. We did an analysis across 36 countries in Africa looking at health insurance coverage. And what we found is that only generally the health insurance coverage across African countries is quite low. Only 4 out of the 36 countries that we analyzed had coverage above 20%. And we also found that in health insurance as a mechanism was characterized by very high inequality. So, the high-low ratio was about 4, essentially meaning that the richest in the society had about 4 times coverage compared to the poorest, signaling that this is a financing mechanism that not only results in low coverage, but also results in a lot of entrenched inequalities. And when you look at global health spending, or health spending across low and middle income countries, you see that the contribution of social health insurance to total health expenditure is quite low in low and middle income countries, ranging from 1% in low income countries to about 7% in low and middle income countries. Just again reiterating the fact that the potential for social health insurance as a mechanism for mobilizing additional resources is quite low. When you think about the equity aspect, and here I'm focusing on equity in contributions, we did some work earlier, around 2017, 2018, looking at equity contributions across African countries. And what we generally find, even though there are few studies across few countries, what we generally find is that direct taxes and general taxes are more progressive. In other words, the rich pay more. Indirect taxes and mandatory insurance have mixed fundings, so it depends on context. In some settings, they're progressive, in others, they're regressive. Private sources are always regressive. So again, reiterating the fact that you have to think about the equity aspect of whatever financing mechanisms that are selected. Efficiency gains as an option, there is potential. Literature shows that there is potential to raise additional resources to the health sector through efficiency gains, and potential areas include focusing on pharmaceutical policies, so procurement, pricing, provider payment mechanisms, human resource policies. So for instance, in Kenya, in 2017, we had a doctor's strike for 100 days, followed by a nurse's strike for 150 days. So in total, you have health workers on strike for a whole year. So you can imagine the inefficiencies that a system that's characterized by such will have. Public finance management reforms are a target that are commonly mentioned. For instance, in Ghana, the health budget absorption is about 51%, essentially meaning that they're losing out on an additional, on about 50% of resources that is potentially available to them. So there is potential from efficiency gains, but the empirical evidence tells us that it doesn't always translate to more resources for the health sector. And
2 more minutes, Edwin.
And there's an analysis that has looked at how can we ensure that efficiency gains translate to monetary or rather budgetary gains for the health sector. And it proposes 3 potential conditions. One is having a very well-defined efficiency interventions that target inputs. The other is ensuring that those interventions are quantifiable in terms of their gains. And the other is ensuring the PFM mechanisms allow for the gains to be kept within the health sector and to be reprioritized. So examples of interventions to improve efficiency gains, including strategic purchasing approaches. So for instance, in Thailand, using health technology assessment to inform pricing negotiations has resulted in significant savings in their pharmaceutical procurement. And you can see that situations where drug prices reduced by more than a half, unlocking additional resources. Again, another example from Thailand, moving from open-handed provider payment mechanisms to capped provider payment mechanisms, and comparing what the effect has across 2 schemes, so the UHC scheme and the civil servant scheme. And you see that the expenditure in the UHC scheme is 4 times lower than the expenditure in the civil servant scheme, barely by just using a capped provider payment mechanism rather than an open-ended one. So there is potential for gaining fiscal space from the different approaches, but the approaches that have the most potential are the ones that are combined. So for instance, here you have an approach that combines improved efficiency and increased prioritization, having a potential for about 90%. So in summary, what strategy works to improve financing for UHC and LMICs? There is really no one-size-fits-all approach. Strategies have to be calibrated to context. Multiple strategies work better. The evidence shows that economic growth, budget reprioritization, and efficiency gains have more potential compared to earmarked taxes. Strategies within the health sector control include advocating for more reprioritization and efficiency gains. And here a focus on strategic purchasing reforms, PFM reforms, governance and accountability to address things like corruption and reprioritization. It's not all about the money. You also have to think about equity, efficiency, and sustainability. And we have to move beyond potential to think about what is practical, so focusing on political economy. And one of the things that countries need to think about is to consider transitioning from ownership of reforms from bureaucrats and politicians to people. So think about the example of Thailand, for instance. Thank you.
Great, thank you very much, especially providing lots of empirical evidence on what actually happens. Because your last sentence said going from the idea to the practical. So, and again, we'll come back to more discussion and questions. You can also take a look at some of the questions that is already sent to you in the chat box as well. So let me now invite Bill Shao to give his ideas.
Good morning, evening, or afternoon, everyone. And I'm glad to give you a different dimension to what Evan just presented from what RJ and the World Bank has summarized as 5 sources to fund healthcare. The problem in healthcare in low income and lower middle income countries is well known. First, of course, is lack of adequate funding. And second, though, at the primary care level, there is a problem that no one has highlighted yet in this presentation, namely that government has not been able to provide and manage healthcare or primary care at the local community level. Usually they can manage up to the sub-district level or district level. So what I'm going to present is an idea called cooperative healthcare, which draw from the historical experiences of different countries that showed approach that can mobilize some resources for primary care as well as deliver primary care at the local community level. And I want to make clear that what I'm going to present is requires some assumptions about that country. And that is outlined in this slide. Next, please. Based on the historical analysis and the inductive reasoning I'm using with Winnie Yap, we're writing a paper called A Theory of Cooperative Healthcare. That is, we want to rely on a capital that low-income, lower middle-income countries have, actually advanced countries have less of. We as economists know there are human capital, there are physical capital. However, literature and the research document, there's a third capital, which is social capital, that exists in much greater degree in low income and lower middle income countries. Now, what is this social capital? When you are living in the same community for centuries, there's some social cohesion, a mutual connection among the neighbors. Next. And then you establish the social norms, sanction the social behavior. The social system is fairly close. Through industrialization, that social system is going to be broken. And fourth is there's a trust among the neighbors because we know each other. And last, but is then through that trust, we're willing to help each other. Next slide. So in principles of cooperative healthcare, we rely then on this social capital to produce community cooperation and self-reliance, but the government still play a role, subsidize the poor people. However, it's important to emphasize the provision and delivery of healthcare at that local community is not controlled by the government. I want to emphasize in my work over 40 countries around the world, including Southeast Asia, India, China, Africa, I have not found most countries can actually manage healthcare at the village level. They can get it down to the sub-district level, but they do not get down to the village level or the neighborhood level, where people want convenient, easy access of primary care and common drugs. That's where I think the government policy has gone astray from what people want versus what the professionals, medical professionals, and policy specialists think this is what people ought to have. So next, please. So then what's a way to develop a system that people are willing to pay? Prepay. That means first you have to actually show they can gain benefits. And their money will be used effectively for them locally. And second, you rely on people's social capital that are willing to help neighbors when some financial strike struck or illness struck. And this, next, please. So what are the potential gains? From historical experience, we see that people can gain trusted practitioners and drugs. Right now, at the local level, people are relying on private practitioners, which they don't really know who's qualified, who's not qualified, and also drugs, ineffective drugs are in wide circulation. So the trust is very important if you set up a local community in a neighborhood or in a village level. You can lower the drug costs through bulk purchasing of drugs. That's already been brought out by everyone. And you can select a qualified practitioners to provide the services. You can improve the quality of service. And then RJ did not point out the major reason to the cause for impoverishment in India, as a study Harvard team just completed in Odisha, a poor state in India. The major reason is people pay out of pocket for drugs. It's not from hospitalization. So you want to reduce that. And we found the same thing in China when we did a study in China, where China was at the lower level of economic development. Next, please. So where do we rely on this? What historical experience have we relied on to draw these conclusions about social capital and the local management of primary care? The earliest documented experience is from Japan. Japan set up these local cooperative healthcare back in the 19th centuries when Japan was a low-income country. Thailand's health card was based on the same thing. Indonesia developed the Dental Sahar, which you probably never heard of, actually was blossoming, covering 20% of the Indonesian rural island population back in the late 1980s, early 1990s. But the propaganda, I call it propaganda, ideological propaganda pushed by USAID, tell them you should abandon that. That's a bottom-up approach, it doesn't work. And then Indian government abandoned it. I have examined the Uganda's funeral health funds, how they're trying to do local mobilization of financing and the local control of primary care. And of course, on a nationwide basis, that we only have two documented cases. That's China's cooperative medical care when China was in a lower income and lower middle income country status. And right now, of course, Rwanda. So the cooperative healthcare is a concept that's derived from historical experience evidence rather than using economic theory from theoretical axioms. So in other words, I'm putting forth, along with Winnie Yap, about this cooperative healthcare from an inductive reasoning from historical experience. And I want to emphasize, this may not a model that fits all. So that's why I highlighted what are the assumptions of what conditions exist in a country. Next.
Bill, 2 minutes.
So let me just summarize then, what is cooperative healthcare? In this slide, you mobilize the finances from the household. Even in the poor countries, you see the data shows people are paying out-of-pocket costs. So you have to induce them, persuade them to prepay. And the government and donors can subsidize the extremely poor households. Rwanda find that 10 to 15 years ago, households can pay $7.50 US dollars per household. In China, was the same thing. But nowadays, they probably can pay $2.50 per person. That's the kind of capacity you can mobilize. And then I want to emphasize is integrating the finance and delivery of basic healthcare. This is not only a financing scheme, it's a system approach. You use the money locally to deliver it and manage the delivery of primary care. And then you integrate the upward with the sub-district health centers, which are staffed by the physicians, and also there may be 20-bed hospitals. And so I want to, in summary then, I want to say what I'm presenting, this is in a paper jointly co-authored by Winnie Yap and I, is on use the strength of the low-income countries, which is social capital, and to develop a bottom-up approach to finance and deliver basic primary care and drugs to the people. Thank you.
Great, thank you, Bill. Keeping in time, and so again, we will have lots of opportunities to come back to discuss with the audience and other panelists. So can I invite Joe to give your perspectives?
Yes, great, and thanks. Am I coming through okay?
Yes.
Good. So I am going to follow on Bill's talk and that of Ajay and Edwin. Some of the points, I'm going to make just 8 points, but this being me, there'll be a few sub-points as well. Some of them will be in stark contrast, shall I say, with what Bill has just proposed. But in fact, others are going to be quite consistent with some of the important messages that he provided. And I also want to congratulate Bill for actually offering a solution rather than just talking about problems. And I generally talk about problems, so I think that's quite useful. I think there's some middle space, but we need to find it with some nuance. So to begin, one of the points that's really around the framing of the session is, how do we find the money? And I'm not sure that that is really the fundamental question, or how you frame the question might lead you in the wrong direction. I mean, typically it goes, there in terms of, oh, there we go, saying that we need so many billions to reach UHC, and then we do an assessment of fiscal context and then somehow discover that we don't have enough money, as if that wasn't known. And that itself is okay. We know there are large gaps, and that work really needs to be done to give an idea of the magnitudes that we're talking about. The problem has been what has happened with the focus on the gap. One has been, for example, to say that, oh, then we must look to this wonderful term of innovative financing as our only hope. Or a second saying, oh, this is all about increasing donor funds. And we've seen how that really hasn't worked out, especially in the context of the COVID response. And I think this last part, which is maybe more to the point, which is often this idea that we in the health sector are going to be more effective at mobilizing funds than those whose job it is to mobilize funds, which is those of the national tax authorities. So my second point is to reframe the question away from the gap issue and get it right. We have to recognize what the implications of that are, is that we're not going to fill this gap right away, right? And that it is something that takes time, that is a process, and we need to build systems in that process. Second is to move away from this idea, at least mentally, of achieving UHC rather than moving towards UHC or pursuing it. There's no threshold. There are targets in the SDGs, but even countries that have already met those targets still have work to do to reduce the gap between the need for services and the use of services, for example. So we need to reframe that. We also need to not let the funding gap drive us into solutions that have been proven to fail, particularly about private voluntary prepayment, which we'll come back to on Bill's point there. And really that we don't waste time on that. We focus more on the design of longer term, what I call system building actions, while we're attempting to address shorter term priorities. And I'll come back to this in a minute or two, but just to say that we need to focus not just on elements of design, but really on the institutional strengthening that's needed. And the institutions that are actually responsible to learn and adapt from their own experience and make change at country level. So one point now is, and maybe the third point with a few subpoints, is we have been to some extent, had been, I should say, prior to COVID, celebrating the gains that we'd seen in service coverage over the past 20 years, that there's been this improvement, increase on that dimension of UHC. But the problem is that, that's an aggregate, and we are really fundamentally talking about an equity challenge here. So we need to really focus on the distributional dimensions, and those are likely to become much more challenging in, they already are this year and in the coming few years, because of the way that the unequal effects of the economic consequences of COVID both around the world and within countries as well. right? As well as the implications for the fiscal recovery in many countries. So this is one way to do it. We need to look at detailed disaggregated data to unpack inequalities. These blue dots are measures of unmet need. This is in the country of Georgia and the Caucasus. And basically, you can see on the far left that twice as many people in the poorest quintile were experiencing unmet need as compared to the next three quintiles. And then, of course, much less in the richest. So we really need data like this that unpacks these inequalities. We have other types of data like this, looking at specific services, in this case, immunization rates across quintiles. So if we're serious about this challenge of the 2 billion or the 2.5 billion, then we'd have to be serious about the disaggregated data and what that implies for policy responses. Now, next, and maybe this is perhaps the biggest contrast I would put forth with Bill's points. I mean, yes, those ideas were good and it would be great if it worked. But what we've seen in countries, and these are just some examples, is that when you have systems of voluntary community-based financing, and community is loosely defined, but in these cases, local level schemes, largely NGO run and led, you tend to get a huge fragmentation, you get low levels of coverage, and importantly, the bottom line there is extremely low levels of health expenditure. So I very much agree with Bill's point that we need to be thinking about local ownership and local accountability, but that doesn't mean that because those things are important that we can dispense with things we, as I say, one of the reasons why there's such a field as health economics is because of the phenomenon of adverse selection, right? So we don't wish that away because we need more money or that we want local ownership. We need to combine that local ownership and accountability with a different form of financing arrangement. Next, and related to this, is that many countries have gone with the route of saying we have social health insurance for the formal sector, but we're going to get the informal sector to contribute and they will join and so on. And you could even make that mandatory by law, but in practice, it doesn't work out well. And this is a great bit of evidence produced by Santiago Levy, who was the former head of Social Security in Mexico and head of policy at the Inter-American Development Bank. And what this shows is that informality is not a fixed condition, that you have these transits of people moving in and out of formal sector status. And where health coverage is linked to that, that means health coverage gets changed. You go into health coverage, you go out of it. And one of the studies from Mexico showed, for example, how damaging this was for quality of care, for example, in showing worse outcomes in terms of, I think, type 2 diabetes, precisely linked to these transits in and out of coverage. And it's also very expensive to do this type of tracking. So it's really a question I would like to pose for everybody who's trying to go this way, is whether this type of complex financing arrangement is really worth it. Fifth point, more now towards what to do. One of the things to do is actually say, if you want to reach more people, then you need to focus on population-based functions and services, what we're calling in WHO, and I think hopefully elsewhere now, common goods for health. And in many ways, this puts into practice some basic fundamentals of welfare economics about dealing with public goods and externalities and so forth. But quite concretely, we're talking about population-based services or functions that have very large externalities and huge impact on human health and welfare. And some examples given below: health taxes, not for the purpose of raising money, but for the purpose of improving health. A lot of the work on environmental control and regulations, especially also water and sanitation and waste management, that can impact the health of millions of people in poor and remote areas, even for those who don't have good access to individual services. So it's critically important that we do that. Next is to think about what is maybe more our bread and butter in terms of the discussion of health financing for individual services. And what is it that can work? We've mapped out these two broad categories of approaches, one based on non-contributory-based entitlement, meaning that the entitlement to services is not linked to contribution, but whether it's for everyone or being below the poverty line, or however that is defined in a particular country for a particular disease or condition, for example. And on the right are the contributory-based approaches. What I would say is, while the title of this slide says these are options that can work, the unsubsidized voluntary prepayment cannot work. And there's no country in the world where that has actually led to any meaningful change. And in the examples, some of the examples Bill was given, including Rwanda and China, they fit more under that item 2 in terms of contributory-based approaches. It's possible for those to work. It's still difficult. It requires substantial public funding. In each case, I believe in China, it's about, the government puts in about 80% and individuals about 20%. In Rwanda, the government funds fully 25% of the population as poor. So there's very high subsidy. There's very active local authorities to ensure the system works. And behind each, and something not necessarily replicable, is a very powerful central government that is effectively able to instruct local governments on what to do. Well, what has been more successful, and I think for low and middle income countries, it's more on items 3 and 4 here, about entitlement for some people to a range of services. So we heard Ajay talk about the PMJ arrangement in India, completely non-contributory entitlement. If you're below a certain level of income, you're automatically covered, fully tax-funded arrangement. And then some other examples where you have the entire population could be guaranteed specific services. So one thing I want to show as an example, and my colleague Hélène Barrois, who's been cited in a few other times today, has put together some work with colleagues looking at the experiences with user fee removal policies in a number of countries. And beyond the fee removal policies, or I would say underneath them, is a really comprehensive and deep system reform dealing with public financial management practices. So the shift away from input control to budgets estimated by outputs, formulating by program lines, direct payment of providers from the budget into provider bank accounts that they could directly manage and report on. They had the autonomy to manage, but held accountable for the reporting on outputs. And the entitlement to services is non-contributory and free for those defined services. We have more on just what we would call our 19 attributes of good practice in health financing, which we're starting to apply to help guide financing reforms, not as blueprints. This still requires a lot of local adaptation, but in terms of the directions or signposts for change. And then last, and I think to come back to one of Bill's points, which I think is critical, is that we have generally focused our discussions and much of the policy debate about what can we do in health financing to get people into insurance schemes. And for me, that is fundamentally the wrong question. The right question is, what can we do to reduce the barriers to effective service use and improve financial protection for the poor and vulnerable? And a lot of this means that we're not going to deal with it. We're not going to make these solutions by just trying to get people into schemes. We need to focus more on how to get services to people who can't get to services. And this is where I very much agree with Bill, that where governments have failed is trying to do that through a kind of centrally planned approach to service delivery. That we need instead to start thinking about local platforms for people at subnational level to figure out what are the barriers that are being faced here, how do we get around them? And whether that involves doing outreach or contracting NGOs or cash transfers, whatever it takes, that the central level can set some principles and objectives, but it can't create those service delivery solutions at local level. That said, what we don't want to see at local level is a plethora of different financing schemes with different information systems and platforms that could never scale up. So it's really to kind of apply those ideas and also thinking about local accountability. Edwin made this point at the end of his talk as well about shifting that accountability or ownership from bureaucrats to citizens, I think is really critical. So last technical point is really to say, whatever is being done, think about the foundations for universality from the beginning. So we want to do things on a population-wide level. for things like, patient data forms, moving towards national databases on activity, even before you have the resources to pool all the funds for everyone, right? So that will lay the foundation for future progress. And we had very good experience with that in Kyrgyzstan, where I work, for example. Consolidation of certain functions that should not be organized by program or scheme, but at the level of the population. And then fundamentally work on this PFM strengthening as the core or basis for any meaningful change. And the last thing I would say, and we have a number of growing examples, is to ensure that systems create the space for institutions responsible to think and analyze. It's not just because this is IHEA and we're trying to promote the role of health economists. It could be others as well. But we need to look at examples. I mean, where Edwin works at KEMRI, at the IHPP in Thailand, and Kyrgyzstan, we had the Health Policy Analysis Center. There's many of these around the world. And at least in the international sphere, we've tended to focus much more on short-term solutions and indicators rather than this type of institution building. And ultimately, that's what's going to matter for figuring out the problems that arise in the future. So to conclude, just to remind us that financing not the solution to an accounting problem. We have to do an explicit approach to address the poor and focus on domestic institutions. What I'm less comfortable with, and I think Bill made the point, and it's really critical, these last 2 points, is that all of this session is based on the assumption that there's a shared objective around equity and reaching the poor. And right now we're in a crisis of values. And I think the issue is, in a sense, how do we rebuild or build the social capital that Bill was talking about? How much solidarity do societies want? And we're also at a stage where the legitimacy of central authorities is increasingly under question. So as much as I might love to have a large centralized pool for 1 billion people, it doesn't look like the politics and the political economy support that. So we need to kind of think about how to respect the principles of health financing while recognizing and engaging on the value issues that are a real challenge to progress. Thank you.
Great, thank you very much. Can I just invite all the 4 panelists back with your video open? So Ajay, Bill, Edwin, and Joe, all of you. I'm going to have the panelists have a little discussion among themselves. So I'm going to ask Ajay to pose a question to one of your other panelists of your choice.
Okay. So let me see. So, very, very interesting presentations and covering different dimensions. So, there's this philosopher named Victor Fuchs. I think Joe is the one who introduced me to his work. And I think the point he makes is very powerful, that for universal health coverage, the mechanism, you need compulsion and you need subsidization. And basically, in the presentation that Bill made, he's making the argument that the compulsion is coming from social capital. This concern is coming intrinsically. It's not a compulsion coming from the government. And I was just wondering, coming from a country where there's so much caste-related issues, religion-related dichotomies, I just don't see that kind of a social capital coming together at the community level to the same extent, perhaps, that it can happen in other countries, where there are these social inequalities. And I was just wondering if he has any thoughts on how can that actually be nurtured rather than taking it as given that there's going to be this social capital that will create this compulsion. What can be done to actually generate that social cohesion is also a question, I think. Over from me.
Right, I take it that that's a question for Bill. So Bill, go ahead.
Thanks, Ajay. That's an excellent question. And I will not say all the local community has social capital. That's why my first slide says assumptions. So you need to examine the local local conditions for social capital. But in terms of even India has, for example, tribes and also have castes.
Mhm.
So India is a special case that is really divided by tribal religion as well as caste. So this is particularly difficult for India. However, in Odisha, I visited some villages that predominated by certain tribes. And now if you look at the India, there are many so-called self-help organizations. They're usually run by women. And actually, they're widespread in India. And usually they cannot break down between the castes very much, but they can actually break down even between the different tribes. So I would say when you have a very divided religious or social caste, maybe it's very difficult, but even in India, I think there's a diverse condition. And because you see these self-help groups flourishing, particularly among the women groups, so they can get organized at the local level. In a country like in Africa, I think they tend to be actually tribal in many localities. And the religious organizations actually could be a very powerful organization to mobilize, to organize local efforts, I will argue. In China, China had done this nationwide, mainly when China did not have such a religious or other kind of division within a local community. But second, there was central government edict. And I will say what works in Rwanda partly is the central government gave legitimacy to this idea. That's why Rwanda was able to push it to a nationwide basis. And so you brought up a very important question, and that's why I would argue countries, if they like this idea as a potential way to fund and organize primary care at the local level, they should actually experiment, not just say, we're going to actually take this as a national policy. That's what Rwanda did. And that's what China did too, by the way. Before China pushed it out, China experimented for 8 years. That's what Mao Zedong did before he pushed out in 1965.
Thanks, Bill. Does Joe or Edwin want to respond or add to some of the conversation, the past conversation between Jay and Bill? Joe, you're unmuted. You want to talk?
Well, just actually to pick, I mean, in a sense, behind this question, and it's really maybe, I think both for Edwin and Jay, but following up on this is a little bit about the willingness to redistribute in ethnically diverse societies. Now, I shouldn't say it's just there. I mean, Bill didn't mention the United States, which is increasingly tribalized on political grounds, and the willingness to redistribute is certainly under threat in that case as well, if it, and the real questions of posing it. So this is not just a lower middle income country issue, right? But the real question is in the context, I think in both India and Kenya, right, where you have devolved systems, and even if the central government has an objective to address the inequalities, what have been, I mean, beyond just intergovernmental transfers, apart from sending money, the ability to actually influence subnational authorities to address priorities that are at least seen from the center. And I guess the question is, are they perceived locally in the same way, and how effective have those instruments been to really address change at subnational level across the country?
Edwin, you want to add to that, or?
Thanks. Yes, yes. So a couple of points there. One, so there are several issues there. One is an issue around the willingness to redistribute. And I'm going to rephrase this a little bit and add a question to Ajay so that when Ajay is responding, can respond to this, is what are people's thoughts about this tension between decentralization as an ideal, as a governance ideal on the one hand, and
you're breaking up a little bit.
The need to reduce. Sorry, I hope, can you hear me now? I hope people can hear me now.
Yeah, yeah,
great.
Okay.
So my question to Ajay, which is a reframing of what Joe has asked, is what are his comments from the Indian experience about this tension between the governance ideal of decentralization? Decentralization is seen as a good thing within of reducing fragmentation, you know, and there's a tension there. And how do you address that within a decentralized system? And I say this because in Kenya, we recently, well, I mean, it's been about 8 years now. We decentralized our governance arrangement, while at the same time made a commitment towards universal health coverage. And it's made it quite difficult for us to agree on a health financing strategy, because while the health financing folks are trying to push towards, fewer pools, more centralized pools, and so on, we live in a reality where there's decentralization, and every county would like to run its own scheme. So that tension exists, and it threatens progress. So that's a question to Ajay. But on the question from Joe around whether, in a decentralized system, national level priorities or national level actors can provide, or rather can have influence over local priorities. I think it really depends. I mean, so in Kenya, we've gone through a period where our devolved systems are quite new. And when they're quite new, then the local leaders are struggling to assert themselves. And so any form of advice or guidance from the national level is always perceived as an infringement of this sort of rights and mandates of the local level. So I think over time, when decentralized systems mature, maybe that becomes easier. But earlier on, as a system decentralizes, there's a lot of tension and there's a lot of political considerations.
So Ajay, would you like to respond to that?
Yes, I think that the point from Joe is very important. And I think that's implied in also what Bill was saying, that when you're looking at a system of prepayment and pooling, it's not just pooling of health risks, right? Inherent in any mechanism of pooling is also this concern for redistribution, to be able to redistribute from the well-off to the poor. And so as a system matures and becomes bigger, those considerations are even more important. And they are definitely implicit and sometimes even explicit in this whole system of intergovernmental transfer systems. And I'm getting a bit perturbed today why Joe is going on dismissing financing. States have the authority they are sort of accountable for delivering healthcare, but they don't raise all the revenues. The revenue raising authority is centralized, and this is even worse at the local government level. So the system of intergovernmental finance transfers is very, very important. And of course, they can just make it unconditional and give it across the states. And that goes to Edwin's point. But I think there's also this issue. Yes, it sounds wonderful that we want to localize everything, that communities know their problems and can solve them. But there's a huge challenge of capacity building, not just in terms of inequality in finances or ability but just the capacity to plan. And so that's one very attractive thing that India has done, is that it's giving this sort of centralized platform and ecosystem without having too many controls in place. in terms of how the system will function on the PMJ, for instance. By platform, I mean, how would you target? States can target more than what the center says. How do you pay bills? So there's an electronic system that's covering almost the entire country. So the ecosystem is there to allow for the states, not only for those that are lower capacity, to get that benefit of having some centralized hand holding, not just in terms of financing, but also in terms of governance, but also the ability to learn lessons, what we call here cooperative federalism from, there are clearly some states that are across the charts in terms of what they're doing. And very important for allowing that kind of sharing of lessons and capacity across states as well. I think it's a key aspect under decentralization. And of course, you have also the issue that as you decentralize more, you also end up potentially having the problem that you might actually increase inequalities across states because of differing capacities. Even if you try to correct for the financing inequalities. So that challenge has to be kept in mind, and there is kind of that role for stewardship function of the center to enable that. In India's case, the third tier of government, the local government, the decentralization is not complete, especially for health. But some states like Kerala have done well in terms of really decentralizing down to the community levels. And using, but combined with very good governance, good accountability, it helps, literacy of women is a key factor in enabling that. And there are other things that play to allow for that to happen. Over.
Thanks. Joe, do you want to add anything? I mean, Edwin also has a point for you.
Yeah, so, well, if I followed correctly, I mean, one of the things I think that has, that we need to conceptually unpack is around this difference between decentralization and autonomy. And for me, in the language of health financing, the decentralization discussion is around responsibilities at the organization of pooling and perhaps purchasing, right? But autonomy is different. Autonomy is about provider level management. And what has happened in when we, sometimes their assumption has been in some countries that if we decentralize the resources, then things will work out, things will follow, what's best for the local population. But by not separating, and Edwin knows this better than I, that like in Kenya, when this was done, facilities that formerly had autonomy to manage had it taken away by local governments. And it's actually hard to track what happens to the provider level. So having a clear distinction between local government and providers is really important, I think, in terms of thinking about, for example, payment systems. So I think that part is fine. But this general point about, coming up with a balance between the political realities of devolution versus what we're trying to do in health financing is a big challenge. One example I would give that I think is relevant because it was kind of an enforced decentralization, which was the peace settlement in Bosnia and Herzegovina, however many years ago that was, created a system of government that did not allow effectively revenue sharing for the most part across each canton, as it was called as here in Switzerland. So for a country of 3.5 million people overall, there was something like 13 territorial or 11 territorial health insurance funds, very high administrative costs, very small arrangements. But what they were able to manage was to say at the federal level, all they could do was create a pool for tertiary services. For example, they couldn't touch the other. So it wasn't perfect, but it was an example of saying, okay, what can we do given the political constraints that we have in order to get some pooling beyond the local level? So I think this was also, we need to look at examples, not of what is perfect, but what is feasible to implement in different contexts. Anyway, that is an answer. I'm not sure it's an answer to the question I was asked, but I better stop there.
Okay, great, thanks. Let me go back to Bill. Your turn to pose a question to any of the panelists.
I want to first clarify a point with what Joe said and then pose a question. I want to clarify that I have examined community financing. There's a whole wide range of community financing when that term became popular back in 1980s, 90s. So it's like calling, let's say, birds as one species. And meanwhile, there's such wide variety. So I want to point out the cooperative healthcare is what we have sorted through, Winnie and I and other researchers, sorted through to pick out what kind, that particular kind of community financing seemed to hold promise, okay? So the 4 countries you gave that failed, I totally agree. Actually, most of community financing scheme fail to really to expand or sustain yourself. And but which really sort of worked, that's what we were trying to pick out here. The question I want to ask you is this. You're emphasizing that we should not focus on financing and the financing gap. And RJ already asked you then, how do you deal with that? Well, I will argue money is the mother milk of healthcare. Without that mother milk, can you actually provide access to healthcare? Your argument is domestic institutional reform could do it. Then I'd like you to elaborate on that.
Sure, and thanks. I think actually what you said about community financing is important. I also, in much of my work, try to unpack labels and not, because as you know, terms also like social health insurance can mean radically different things in different places, right? So we need to unpack these things. And what I think you're doing and encourage you more is really to get at what are the critical attributes of what you're talking about in terms of community financing and flesh those out more. And then we can see where we can meet to have that discussion. But you're right. I mean, we shouldn't talk just about the label. In that regard, I don't believe I ever said not to focus on financing. What I was suggesting was that driving policy solely on the basis of how do we fill the funding gap is not productive and has actually led to some very problematic responses. So that part is important. The other part of it is that, there are things, and I've always worked within the sector, right? And so there are things we have some comparative advantage or can do well in the sector, and other things that are very important, but might be better done by others. And in that sense, that's my message, that the issue around taxation in particular, if we're having, if the health sector is having trouble collecting money from people in the informal sector, I would pretty much imagine that they're not paying a lot of individual income tax either, right? Or other types of taxes other than maybe consumption taxes. So the question, for me, the longer term question and broader question is how to improve tax and revenue systems. What I think we can focus on in these institutions then, so just to say, of course, the money is important, the level is important, and we can, make the case, but the solutions will largely be found outside of the health system in terms of the revenue side of things. But in terms of the management of funds and the institutions, it's really these two areas, that there's a lot more that can be done about spending better, right? Spending, like I talked about, focusing on the common goods, the things that will reach improving health, what might be called not health financing, but funding for health, right? That we want to fund things that might even be outside of the sector, like clean water and sanitation, environmental controls, and so on, because of its impact on health. So those things are really critical for improving the situation for a lot of people. And then the other part is simply what I talked about, not simply a critical area of work, which is all of the work on public financial management, to basically say, we have this level of funding that is provided through the budget, and we have these services, and maybe those services have been costed, but there's no mechanism in most countries to translate those resources into those services, because those resources, well, we have to pay salaries, and then we have to pay utility costs and so on. So the PFM reforms that are happening is to be able to better match budgets to priorities, those priority services or priority populations. And why this is important is not just because it's a good idea, but also fundamentally, it's not a pilot project. To do this, you have to change how the public finance system works in a country. So these are really critical for not just, the particular examples I gave about fee removal. It's really about getting much more flexibility into the public sector, including doing what you talked about, which I really think is important, about local level platforms to really think through how do we organize service delivery at this level, and not pretend that a remote central government can actually know the best way to get services to people in a remote village. So I would, in terms of what you proposed, I take a lot of it. I would just kind of separate the revenue raising point out of it, and to keep more of the local accountability, the management, the decision-making parts of it as being primary. If there's some resources, fine, but we're not going to solve the financing problem at that level, but we could solve a lot of other problems. So I'll leave it at that.
So can I ask a question as the moderator? There is PMJAY is very much focused on hospital care. And we also know in India and in many other places, there's quite a bit of money that is spent on out-of-pocket spending. And I think there's a question of, short of raising more money, how do you risk pool the existing out-of-pocket money into some form of pooling mechanism? And I think that's a question that many countries are trying to wrestle with. And so what are your thoughts of all of you? This whole idea of risk selection, adverse selection, is because people anticipate that they would not be using the services. Therefore, the healthy people are not buying or prepaying into it. And I think the fundamental problem of covering hospital care makes it much worse in terms of adverse selection. And if you can cover primary care and drugs, I would say every family, if you do any survey, no matter how young, how healthy, they would be using some in a year, whether it is themselves or their children. And I think that these multiple pieces need to put together to be thought of. It's not just that there's adverse selection, but it depends on what is being covered. I wonder what RJ, Joe, Bill, Edwin have thoughts on that. Bill raised his hand. Yes, Bill. Yes, Bill first, and then RJ.
I'd like to elaborate what RJ said. He said, you see, when you do risk pooling, there has to be some kind of compulsion. That's what both Joe and RJ mentioned. The compulsion is through the tax system or through the social pressure. And I would say the cooperative healthcare is rely on this so-called social capital, which is using the community to create the social pressure. And as you know, I did that social experiment in China, which is published paper. This is more than close to 15 years ago. The healthy young people, even they spend out of pocket, they do not want to join prepaid. So what we did is we agreed in a village, if 60% of people vote that they will prepay, then the other 40% have to do it. And if they don't, they receive social sanction. And that's one way to deal with adverse selection. So many of the community financing scheme failed it's because adverse selection. So that's why I raise my hand to say, rely on social capital. If you exist in a community level, you can actually do things. Okay, but the government has actually give legitimacy to that, and so that's what I would like to explain.
Okay, RJ, because you have
yes.
your hand raised as well, all of you.
Yes. Yes, I just wanted to respond a little bit. I completely understand where the argument is coming from. This intrinsic wanting to contribute and social pressure, and really what I meant was it's very, it's part of that same logic that you want to get people, whether they're intrinsically or motivated by religion or motivated by concern for the thing, and the same logic happens even with extended families bill, right? When you pay out-of-pocket spending in many low-income countries, you are counting on pooling at the family level. Extended families come together, and in a way, you can see this as an extension of that a little bit further. And there is precautionary savings anyway at the household level, not just out-of-pocket spending on health, but also precautionary savings. That in a way, this community program is a community savings program that that is going to work at a slightly bigger level than at a family. I just also want to make one point that where there's a will, there's a way. So yes, we need to look at these mechanisms, but if the government wants to do this, they will do it. And I just think we shouldn't be passive. So that's why I'm getting a little bit worried about Joe's passivity, saying, oh, let's not get into raising revenues. Out-of-pocket spending is a tax on the sick, is it not? It's a way of raising revenues. Why are we not fighting the way? And I'm saying this with some emotion because I live in a region where choices are being made, choices to prioritize military spending over health, to prioritize fuel subsidies over health. So there is a room for making arguments that perhaps it's not that health should get the entire budget, that health does not get a fair share. And part of the reason it doesn't have to do with these redistribution and other political economic considerations and the perception. It's not just about PFM. PFM is a problem across all sectors. It's an excuse that's made not to give money to health. And I just want to also make the point to you, Winnie. Yes, I think PMJ very clearly, if you have chest pains, it'll cover your hospitalization, but it doesn't do anything to prevent you getting the chest pains to begin with. I think that is, Joe often talks about fragmentation of schemes. This is a fragmentation in the continuum of care. That they're saying, oh well, you have access to primary care through the other program, but really in the future this will have to come together in some way to be integrated and to work. And in terms of finding the financing for it, in addition to making the point that there's a will, there's a way, I also want to point out that there's a little bit more of out-of-pocket spending that currently is not considered traditionally financing. That's out-of-pocket spending on tobacco and alcohol and sugar-sweetened beverages. This is out-of-pocket spending that's just as welfare reducing as out-of-pocket spending for accessing care or on medicines is, right? So there are households that are paying for, and some mechanism by which you can tax that, even if it's not earmarked for the health sector, is also room in the community budget and household budget that could be captured the same way that we're trying to capture out-of-pocket spending on health. This is out-of-pocket spending that reduces healthcare. And I think especially in these times of COVID, given the revenue shock that has happened as a result of COVID, there are opportunities to re-look at these things. And this is one area where the health sector does get involved. And also it gets involved in social health insurance contribution settings, in carbon taxes and things like that. So let's not be passive, Joe. Let's fight Ministry of Finance. And I hate the point that we always hear that, oh, investments in other sectors are going to contribute to health. We always hear that, oh, please invest in education, that's good for health, water sanitation, good for health. Investing in health is important for other sectors, right? Healthy children will not learn. Your investments in education are wasted if you're having malnourished children who have worm infestations or what have you, right? productivity of workers. I mean, people who are diabetic and hypertensive are not going to be able to work. So I think we have to also be a little bit more aggressive in turning the thing around and saying, you are not investing enough in health and you're ending up with all these things that are actually making investments in other sectors inefficient. Not just to say that invest in water sanitation for health. The Ministry of Finance will say, yes, let's build more water sanitation plants. But, so just to have that kind of a balance in place. But completely agree that in terms of PMJ, I think in many ways, if I were designing it, I would have flipped it around and perhaps focused much more attention or to integrate primary care and public health interventions as part and parcel of it. And I hope in the coming months and years, that is the direction in which it's headed. Over.
Right, thank you, Ajay. And I've always been amazed by that figure, 0.03% of GDP from PMJY over a pretty ambitious 40% of the population and a pretty ambitious all hospital care. So it would be interesting to continue to track empirically how much of that money really can live up to the promises as well. So, I mean, in a way, is intergovernment transfer, if the amount is so tiny, I think it's not even a starting point to talk about the transfer. So, but I think both Joe and Edwin has your hands up to an earlier point. So Edwin, you first, and then Joe.
Thanks, Winnie. So I have 2 points to make. One in response to Bill's presentation and Bill's point, and two in response to your question, Winnie. On the issue around cooperative health and thinking through how to make community health, community financing mechanisms work. I think we have to be a bit cautious, and we even when we talk about social capital and social solidarity, we have to distinguish between a willingness to contribute and an ability to contribute. Those are two very different things. So while communities might be willing to contribute to healthcare, the question is, do they have the ability to do that? And we cannot judge that ability by looking at how much they spend out of pocket, because they spend out of pocket by duress. They have no other option, and so they have to spend out of pocket. So we have to ask ourselves, if these individuals who are living below the poverty line and are spending out of pocket on health, if we compel them to pay into a prepayment system, what implication does it have for their household economics or their financial situation? So we have to be sensitive to that. It's quite important. In Kenya, for instance, when we do surveys to look at social solidarity, we find that social solidarity is quite high. So individuals are willing to pay. But then when we look at their ability to pay, the premiums that have been set by health insurance schemes, for instance, there's a disparity because almost 40% of the people in the population live below the national poverty line. So I think we need to be sensitive to that. And just to respond to your question, Winnie, around the scheme in India and what it means to provide actual coverage for people and out-of-pocket expenditure and so on. I think one of the things that happens with health financing systems across countries when they're coming up with these schemes is adopting a very siloed and fragmented approach to health financing mechanisms, so that you have a situation where there's no linkage between efforts and reforms to mobilize resources, effort and reforms to pool resources, and effort and reforms to purchase resources. And we have to go back and look at it as a system rather than as individual intervention. So you have situations where you have high coverage in places like the Philippines, for instance. You have high health insurance coverage, but then you also have high out-of-pocket payments. In Kenya, you have the insurance company scheme mobilizing significant resources, but then they're unable to pay hospitals. And it's simply because there isn't a linkage between decisions about what to purchase and linking that to decisions about, or rather the reality of how much resources have been mobilized and how many people have been covered. So it's about time people who think about health financing reforms moved away from thinking about sort of linear reforms within we are solving for someone accessing care without getting getting into financial problems. And so we have to link all
we've lost Edwin. So hi Edwin, we lost you for a little bit. Do you want to repeat just the last 30 seconds?
Sorry, I'm not so sure where you lost me, but so what I was saying is when we think about reforming health financing mechanisms or systems within countries, we have to take a step back and ask ourselves, what are we solving for? And we are solving for someone out there getting access to the care that they need without getting into financial problems, and that those arrangements should be equitable and efficient and so on. And then work backwards and look at it as a system rather than fragmented functions along that chain. Because that is what leads us to situations where you have high coverage and also high out-of-pocket payments, or high coverage and no link between coverage and services that people are entitled to, and so on.
Great, thanks. Joe?
Yeah, thanks. I needed to actively respond to the charges of passivity, which I assume were deliberately provocative. I think the point, just to clarify, let's say in our own case in WHO, I don't believe that we should be sending advisors to the Ministry of Health to advise them on how to collect taxes or how to collect revenues. And more practically, I mean, one of the more practical questions that comes up, for example, in many countries is, for example, should a social health insurance scheme focus on revenue collection or let the tax authorities do that and they focus on pooling and purchasing? So it doesn't mean not interested in financing. We have to be, and the health authorities have to be very active and engaged in the dialogue on the overall budgetary dialogue in finance, but that's different than deciding to open a new stream of work in health ministries on tax collection, right? So I think that's an important distinction to make, that you can be very active in advocating and engaging with financing and making the case more effectively without doing your own revenue raising. I think on the two questions that, Winnie, that you posed about, and this is an old question, right, that we've never really addressed well, is, yes, there's a lot of out-of-pocket out there. How do we translate it into some form of prepayment, or at least into some type of complementary funding for the system? And I think the way to do that, in order for something to be complementary to something else, means that we have to have the public finance worked out. And where I've seen that done, it was done certainly in Kyrgyzstan, where I was, is that you had a comprehensive benefit package framework. It wasn't about the detailed list of services. It was about saying, for example, that primary care was free for the entire population. There was a group of what was so-called insured people who then had lower co-payments for referral care. You had defined groups that were fully exempt, and then you had this space in the chart that was uncovered financially. And that uncovered financial part, whether that is co-payments or potentially something you could risk pool for, is explicitly complementary to that public funding. It's a bit like how the mutuelles work in France, for example, that you have a benefit package with large co-pays, and then you have the complementary insurance to cover the co-pay. If you don't have that complementary, or if you don't have that comprehensive framework to begin with, where the demarcation of where public finance is not covering, then it's almost impossible to have that private finance come in a complementary way. So I think that part is important. The other issue, though, was I think what both you and Bill talked about in terms of the lower cost services for local risk pooling, the primary healthcare and drugs and so on. And I would argue that you said, yes, you could limit adverse selection in that sense because everybody's likely to need something. That makes it more like savings, right, than insurance. And the advantage of that savings to some extent is that you don't have a problem of adverse selection because you only have what you're entitled to and you're not really pooling very much. But of course, the flip side of that is that the benefits will also have to be limited. And what we've seen in this old work that was done, I think it's cited in some of your work, the review we commissioned in the 90s by Bennett, Kreis, and Monash, looking at all of these prepayment schemes, was that the one that basically worked the best was the Boimanda scheme and what's now DRC, which only covered hospitalization. But it had strict referral requirements. The schemes that were covering first contact care and drugs were rapidly running out of money because they didn't have put in place the cost control mechanisms. And while you talked about being able to control the price, it's really the control of volumes that's a concern in that sense. So we need to really think about, if we're going to go that way, that's fine, but really look at what can be done and how will it deal with people who have chronic conditions. And sorry, last thing, Jay made the other point. It's about the other sectors. It's not a random sort of saying general statement about investing in other sectors. It goes back to this issue of the local platforms and the type of local problem solving that I think Bill was talking about as well. And maybe it's a bit of reinventing of government at that level to say that there needs to be a responsibility at that level to identify and determine what are the causes of poor health in particular communities or my region, and then saying what's the comprehensive approach to deal with it. And it may be that in many settings, it's not only health services. That's part of the answer in that regard. So I'll leave it at that.
Thank you. I think we should take some questions from the audience. And here's a question. Do you think that the G8 agreement on corporate tax, and particularly it's being paid in the country where the value is created, will assist in improving fiscal space for health? Anyone wants to respond to that?
Maybe just briefly, because, well, I don't believe it when I say that, but it's really important. I mean, there's a lot of arguments about, that it's very low and so on, but we're in a situation where there was a race to the bottom, right, of, tax avoidance, and something had to be done to step in. And, there's a lot more that needs to be done, but not just thinking about the immediate results, but the longer term implications of not doing anything are really severe. If we're talking about, I mean, in many ways, this issues of solidarity and redistribution are all about the willingness to pay taxes, in a sense, right? And the extent to which corporations can avoid taxes through this type of mobility is a major threat to the importance of funding the commons, funding basic services. So I'm sure it can be improved. I don't know all the details, but it was critical that that step be taken. So I'll leave it at that.
Winnie, I can just add a footnote to what Joe said. I agree with him completely. I just think it may not necessarily need to fiscal space for health. So that's the point I'm trying to make, that, wherever, even where the tax revenues are there, the share health gets is sometimes not enough, right? It's not prioritized. And that's where you need the arguments, the flip side of what Joe is saying. It should be internalized in all of us, that you need to invest in health because you need productivity, you need better education, you need better agriculture. So that should come naturally as well, because it's not just about looking at what's happening within the sector, it's a choice being made across sectors as well. And in some cases, health may not gain that, because part of the reason is because our counterparts in ministries of health are not able to dialogue at the same way perhaps education people are able to dialogue about, using the language of economics and growth and poverty, which resonates more with the budget holding authorities. Over.
Anyone else? Bill or Edwin want to comment, respond? Bill?
I just want to add what I learned, because we teach minister course, executive course to minister finance from African countries as well as from Southeast Asia. And we taught more than 80 minister of finance. We asked them privately why they do not allocate more to health. Well, the answer is most of them understand the importance of health. However, they offer this answer frequently. The money goes there doesn't translate into actual services that people value. In other words, goes to your earlier point, Joe, about access. It's not just take the money, okay? So this says something, supports your earlier point about changing the domestic institutions. And then I have to ask the question, why the health bureaucracy gives the impression that is unable to translate the money into effective services, as let's say compared to education, which usually get a larger share. And I think that's the important question I like to raise. in terms of your domestic reform domestic institutions, how does the health bureaucracy can change their motivation minds to actually to focus on producing something that people can easily access to and value?
I assume that you're not
Winnie,
expecting a concrete answer.
Right. No, I don't. But I'm just saying that's by teaching these ministerial forums at Harvard, I really learned a great deal about how the Minister of Finance really think about it. And they will talk to you privately over lunch and breakfast. You can ask probing questions, and they don't just give you the public rhetoric. But meanwhile, the Ministry of Health, we also teach the Minister of Health by equal number. The bureaucracy seems to have captured these ministers who are political appointees. And the health bureaucrats seem to want to just protect their budget and their power rather than serving the people. At least that's a general impression I get from what the Minister of Health feels they have to overcome. And that's why I bring up these points.
Right, excellent thoughts, food for thoughts for many of us to really spend more time to think through it rather than dealing with just one versus the other. Joe, you unmute quick.
Oh, it was just to say it was especially important for those of us who are bureaucrats and who work in large. And it is. I mean, it's a big question, I think, for a lot of organizations. It's a political. I mean, that's another session, so we should do that. But doing something on the economics of and whatever politics of bureaucracies would be important, I think.
Absolutely.
Winnie, if I can just add.
Yes.
Yeah, if I can just add, I mean, I think one of the challenges is that the health sector and a lot of functions within the health sector are framed in a technocratic way, and so it is assumed that the problems that are there are technical and the solutions are technical, and that the priorities are self-evident, and that's a challenge. So it's quite important that folks within the health sector begin to engage with the political economy of resource allocation, because you're not going to convince a minister by telling them that it is important because a child will die, because every other minister is also trying to convince the finance minister. So the health sector really, and the people that advise health sectors really have to start engaging with the political economy of decision making if we are to make progress in this.
Excellent point. I think all of the panelists and the participants agree with you. And I was just going to make a quick reflection on public budget management reform. It hasn't been easy, partly. It's also cast in the bureaucracy reform, and it is not just about for health. It is, again, going beyond health sector. That's another challenge. Yes, we know a lot of the inefficiency happen because of the way the public budget management system is set. But same as on the delivery system, we know a lot of bureaucracy for public hospitals are problematic, but then many of these reforms require an overall change of the civil servant system and overall change of the budget management system that goes beyond health. I would conclude by saying that this is a very lively, informative, and thought-provoking session. I thank all of you. And I would like to also say that many of you actually bring out the point of political economy. As president of IHEA, we always try to reflect what is the profession of health economics in terms of our contribution to health policy. And so how do we expand beyond our traditional way of looking at health economics that might make our research and work more valuable and contributing to policy actions. And I think all of you is raising the important issues of thinking about institution and thinking about political economy that goes beyond standard economic analysis. There's still a number of questions in the Q&A box. I think we can take them down and they're addressed to each individual specific of you, and we can send them to you that if you want to respond to the audience. And for the audience, many of you ask if the session slides are available. The recording will be made available soon after I hear concludes. So stay tuned to that. So again, thank you very much, all of you, for a very enlightening conversation on a very important question. Joe seems to apply as an old question, but unfortunately, it is an old question that hasn't been resolved yet.
Right.
And yet it has serious implication on human welfare. And therefore, we should continue to try to work towards it because it has, again, it has implication on people's livelihood. I also would think that, yes, investment in common group is very good, is very important, but I'm sure politically we also have to face the trade-off of investing in something that is focusing on health, but health system also have other goals, including access, financial risk protection, and people want immediate relief of utilization needs rather than waiting for a long-term health improvement. And I'm sure that is a challenge that we will run into as well. So thank you again. And until next Monday, we look forward to welcome you back to the main Congress.